A clot in the lungs, sudden shortness of breath, chest pain, maybe even collapse. How do we confirm it? And more importantly, how do we treat it safely? Let's dive into pulmonary embolism. First steps in diagnosing pulmonary embolism include assessing clinical suspicion and checking vital signs. The symptoms are often vague, like shortness of breath, chest pain, hemoptysis, or even fainting. So, it's important to keep pulmonary embolism in mind when there is no clear explanation. Check also oxygen saturation, since hypoxemia may be present, but SpO2 or oxygen saturation can also be normal. Watch for unexplained tachycardia or in older patients, tachypnea and altered mental status. The first major step is to check if the patient is hemodynamically stable. If unstable, which means the patient has hypotension, shock, or cardiac arrest, you don't delay for scoring or D-dimers, you move straight to imaging and management. If the patient, on the other hand, is stable, then we proceed systematically using the Wells or Geneva score to estimate pretest probability. In stable patients, the next step is to estimate the pretest probability using either the Wells or the revised Geneva score. The Wells score is based on several clinical findings, such as signs of deep vein thrombosis, heart rate above 100, recent surgery or immobilization, previous DVT or pulmonary embolism, hemoptysis, and active cancer. It also includes a bit of clinical judgment, whether pulmonary embolism appears more likely than any other diagnosis. Now, depending on the total score, the probability is classified as low, intermediate, or high. If it's high, we go straight to CT pulmonary angiography. If it's low or intermediate, we start with a D-dimer test first. If the pretest probability is low or intermediate, the next step is D-dimer testing. D-dimer increases when there is active clot formation and breakdown. A negative result essentially rules out both deep vein thrombosis and pulmonary embolism, while a positive result requires imaging. False positives are common, especially with age or inflammation, so the cutoff value is adjusted: zero point 0.5 milligram per liter under age of 50 and age divided by 100 if older than 50. For example, if the patient is 75 years old, the cutoff becomes 0.75 milligram per liter. Now, any value at the cutoff or above it is considered positive. If the D-dimer is positive, or if the pretest probability is high, the next step is imaging. CT pulmonary angiography is the gold standard for diagnosing pulmonary embolism. It shows the exact location and extent of the clot and can also reveal alternative causes of symptoms, such as pneumonia. If CT is contraindicated, for example, renal failure, pregnancy, or contrast allergy, a ventilation perfusion or VQ scan is used instead. A high probability VQ scan, together with a high pretest probability, confirms the diagnosis of pulmonary embolism. Supportive tests cannot confirm pulmonary embolism, but they help narrow the differentials. On chest X ray, findings are usually nonspecific, but two classic signs can appear: Westermark sign, which shows decreased vascular markings, also called oligemia, and the other one is Hampton hump, which is a wedge shaped opacity near the pleura, and it represents pulmonary infarction. On ECG, sinus tachycardia is most common, but you may also see an S1Q3T3 pattern, right axis deviation, incomplete or complete right bundle branch block, or T-wave inversions in V1 to V4. Arterial blood gas analysis can show hypoxemia, hypocapnia, and respiratory alkalosis. And remember, if oxygen is low despite a normal chest X ray, always suspect pulmonary embolism. Lastly, echocardiography can show right ventricular dilation or dysfunction, especially in unstable patients. After confirming pulmonary embolism, we assess prognosis using the simplified PACE score. It includes six criteria: age over 80, history of cancer, systolic blood pressure below 100, heart rate above 110, oxygen saturation under 90%, and a history of heart failure or chronic lung disease. Each factor gives 1 point. A score of 0 means low risk with about 1% in 30-day mortality, while a score of 1 or more indicates higher risk with mortality around 11%. Additional prognostic markers include ECG changes like the ones mentioned earlier, as well as elevated troponin and raised BMP or pro-BMP, which reflect right ventricular strain and may help identify patients at a greater risk of complications or death. About treatment, treatment depends on the patient's stability and risk level. First, if the patient is hypoxemic, you give oxygen. If there is hypotension, you start with IV fluid boluses, but be cautious. Too much fluid can actually worsen the right ventricular overload. If the blood pressure remains low, you can use vasopressors, and norepinephrine is the first line choice, but dobutamine can be used if there is right ventricular failure. For low risk patients, anticoagulation alone is enough. However, high risk patients need reperfusion, and it's either systemic thrombolysis or catheter directed thrombectomy. And finally, intermediate risk patients should be monitored closely since they can deteriorate quickly. Once the diagnosis is made, the first step in treatment is to start anticoagulation. That means preventing the existing clot from growing and stopping new ones from forming. This can be done with intravenous unfractionated heparin, subcutaneous low molecular weight heparin, or oral agents such as rivaroxaban and dabigatran. After the initial phase, we continue with maintenance anticoagulation. This is what keeps the patient protected long term. Maintenance therapy can be done with vitamin K antagonists like warfarin or with direct oral anticoagulants like factor 10A inhibitors such as apixaban or rivaroxaban or thrombin inhibitors like dabigatran. Most patients with pulmonary embolism can be managed with anticoagulation alone. But in high risk cases, when the patient is unstable, in shock, or not responding to anticoagulation, we move to reperfusion therapy. Reperfusion therapy can be done in three main ways. First, systemic thrombolysis. This uses fibrinolytic agents such as alteplase or streptokinase to dissolve the clot. The drug is given intravenously and circulates through the bloodstream, meaning it affects both the lungs and other tissues, which increases the risk of bleeding. It's used in high risk patients which are unstable and we need a rapid effect. Second, we have catheter-directed thrombolysis. Here, the same fibrinolytic agents are delivered directly into the clot through a catheter placed in the pulmonary artery. Because the drug acts locally, smaller doses are needed, which lowers the risk of major bleeding, and this option is often used in patients with high bleeding risk. And finally, embolectomy, which is performed when thrombolysis is contraindicated. It can be done surgically by opening the pulmonary artery or via catheter guided mechanical approach to remove the clot. Before giving a thrombolytic, the first step is always to make sure it's safe. There are some situations where we never use these drugs, like after recent brain surgery or severe head injury, and also if there is an ongoing internal bleed or in anyone with a previous hemorrhage in the brain. These are what we call absolute contraindications because the risk of bleeding is simply too high. Then there are other cases where we have to be more careful. For example, someone with very high blood pressure that's not well controlled, a recent invasive procedure, or someone already on anticoagulants. In these situations, we carefully weigh the potential benefit against the bleeding risk before deciding. If any of these are present, catheter directed or surgical embolectomy might be safer alternatives. So that's pulmonary embolism, how we diagnose it, treat it, and when to use anticoagulation or reperfusion therapy. Thanks for watching, and if you enjoyed this one, don't forget to leave a like and subscribe. Peace out.